Hello. Today we have Dr. Mark Swain with us. Dr. Swain has been a practicing hepatologist and clinical scientist since arriving in Alberta in 1993. He holds numerous leadership roles in the Faculty of Medicine, including the Wenzel Family Foundation Chair in Hepatology, which is a research chair, and he is also the head of the Division of Gastroenterology and Hepatology for the University of Calgary. He is widely published with over 190 peer-reviewed articles to date, and he's also been invited to speak extensively in local and national and international scenarios on medical and research. And he is a fellow of the Canadian Academy of Health Sciences. Welcome, Dr. Swain.
Thank you very much for having me.
So here we are now, some 6-7 months into what we now describe as the COVID-19 world. What's that been like for yourself and for the hospitals in the Calgary area?
It's been, as you say, a very interesting time. I think it tested a lot of the personal fortitude and the structural fortitude, I think, of the healthcare system. And obviously, we never had anything like that before, And from a personal sort of view, of course, I have children, and when you have children and they suddenly are not at school or they're not able to go to work, and my children are older, and so it actually disrupts the normal fabric of life in quite a profound way. And then you superimpose that, and for physicians to have younger children, it was quite challenging because, of course, all of the healthcare's, pretty well everyone, if you needed to go into work and you had young children, it became very challenging, and so that was sort of a side of the pandemic that people talk about. But I think maybe when we think about how we're going to address these sort of things in the future, there has to be some way to make sure that the people who are on the front line, no matter what they do, the people that have to go to work at least have some capacity to have people look after their kids, so they're not worried about all of the risks of going to work, but also the risk of leaving their children at home, maybe with someone that they don't know very well or whatever. Or you're trying to call up friends, call a friend sort of thing.
Did any of that happen ad hoc? Were there things you were able to do on the fly to kind of accommodate childcare?
Yeah. So for me, again, that wasn't an issue, but because my kids are older, but in fact, they would be the ones potentially looking after other people's kids. But but that was a big struggle, and I think there was a little bit of that going on. But I think because it came on, relatively suddenly, if people hadn't really thought what would happen if we actually, have to go to work and our childcare is gone, and so I don't think most people have really thought through, and they always thought, well, maybe if we don't have childcare, like in a non-pandemic circumstance, then you can always usually temporize because there's other things you can temporize with, or friends or whatever. But if everyone's in the same boat, you can't turn to anyone because everyone's desperate. And so it was really, that was quite challenging, and it's an ongoing issue because, of course, everyone's worried about the second wave, and now they're thinking, what can we do to try to prepare ourselves for that? And so, that from a personal point of view, and from a divisional personal point of view, I think has been quite challenging and is ongoing. From a work point of view, of course, it caused restructuring of everything we do. And essentially, they took all of the services that are considered to be non-urgent, non-acute care, and basically shut them down because they were focusing on the mathematical modeling, which was, to be totally honest, was very frightening. And certainly the modeling in Alberta, it was very concerning that the system was going to be overwhelmed if the models that were actively being sort of reported from Italy came to fruition. Then it was going to be a nightmare. And so, thank goodness that didn't happen. But we needed to be prepared for that. I certainly think in Alberta, they really got on top of it, and I have to give Alberta Health Services credit. They really took it seriously, and they reorganized. And I think from a COVID point of view, we were ready for the onslaught as much as we possibly could be. The problem, of course, is that the onslaught, well, not problem, but I guess the good thing is that the onslaught didn't really happen quite like we thought it would. And because Albertans really were quite. They actually, follow what the government said, and they said, when they said socially isolate, and they did, they actually, the streets were empty, and people didn't go to work, and so we turned the curve quite quickly in Alberta, and I think it was because of that sort of community spirit of just doing the right thing. And I think Canadians broadly have done that, which is really quite impressive, actually. And I think when you look at how we've done on the world stage, I mean, it makes you very proud to be a Canadian. I think we've done a great job. The problem, of course, that we now are left with is we took all of this of our infrastructure to focus on this pandemic and try to make sure that we kept everyone that we possibly could alive or healthy who was going to be getting COVID. Unfortunately, what that did was it actually, when we canceled all of these more elective things, I think that we started to see that, first of all, mental health issues have been a big problem, and rising use of alcohol, rising incidence of depression. I think it's very hard to lock people up for 4 to 6 months. Say don't go out, don't socialize. If you socialize, be 6 feet apart. I mean, it's really not the human way, and so I think that's been hugely problematic. And then, of course, all of the procedure-driven things like surgery and GI, where you're doing these procedures often to cut cancers out or look for cancers, or if you can't do that, then you're always worried that people that have been slotted, I guess, as semi-routine or whatever. Well, if they happen to develop a cancer, of course, that's not routine, and so we're now trying to go through our backlog of cases, and it's going to be interesting to see what the impact is being outside of COVID with regards to diseases that really were had to be moved for the COVID pandemic, and couldn't necessarily fall into the normal patterns of the healthcare delivery that we normally give, and certainly. From my own personal experience, there was people that I would call who were at home, and they were obviously very ill, and they didn't want to go to the hospital, and you were there essentially begging them, saying, "I'm going to call the ambulance right now. Don't call the ambulance. I'm going to call the ambulance." So those kind of discussions, right? And so that's a very different scenario than what it used to be, and it's going to take a while, I think, for people to get over that. That fear, and so I think people are coming out of it now, but it's a very interesting study of human behavior, and you want to make people do the right thing, but you have to be there's always this trade-off of causing a fear that sometimes can be hard to overcome when you want to come out of the COVID pandemic.
So different markets are going to handle this backlog, if you will, of all these elective procedures. Is there any indication of how Alberta's going to handle that?
Well, it's the perfect storm in Alberta, of course, isn't it? The perfect storm, meaning that Alberta was struggling already from an economic point of view, and so there were very challenging times, and on so many different levels. But there is not a lot of. They were already talking about how they could cut back, on some of the services provided in a way that was, still patient-centric before COVID even came along. And of course, COVID appears on the scene. All of the structure went, and it was a lot of investment went into forming COVID teams and figuring out ways to deal with COVID. And then, of course, now that COVID's going, there's this backlog of cases. They've had to very gradually open up the capacity, and I don't think there might be a plan from a surgical point of view, but endoscopy, it's really people trying to catch up without adding significant extra time, actually. And so I think we can do it. We have a pretty enthusiastic group of gastroenterologists, and so I think it can be done, but it's going to take time. There is a backlog for sure, and depending on what province you go to, they estimate some of the backlog. Like in BC, I think they estimate 1.5 years for elective surgeries. But obviously, if you've been waiting for an elective surgery, then that it doesn't seem elective after you've waited another 1.5 years, right?
No, absolutely. Now, one of the, I guess, topics that you've put a tremendous amount of work into over your last few years, many years, has been the development of this clinical pathways to treat disease and illness. Could you comment a little on what has been developed at Calgary and with some examples, maybe very relevant to what's been going on with these elective delays?
Yeah. So it's interesting because, of course, my training was in clinical basic science, and so as head of gastroenterology. So when I was acting head from 2011 to 2012. When I became head, I started to really look at the numbers. What profoundly struck me was the wait lists were massive, like massive, thousands and thousands and thousands of people sitting on wait lists that realistically could never be seen. There just was not enough manpower to see them, and so we were in this situation where gastroenterology in Calgary gets about so there are central access and triage, which is about 22 clinical full-time equivalents of gastroenterologists to see these patients. We get about 2,000 referrals a month. And we get about another 1,600 to 2,000 or the colon cancer screening center, and another 300 hepatology referrals per month. So it's a massive number of referrals coming in, and I guess to the credit of the system is we've actually been able to keep up okay. But the problem is our service had really become a service of urgent need. I mean, people that were urgent, I think we were pretty darn good at seeing them in a timely manner. I think comparable to anywhere else in Canada, and probably better than many. The problem was if you had what was just determined to be a routine problem, like dyspepsia or heartburn, or maybe intermittent diarrhea, constipation, these kinds of things which are very common in society, irritable bowel syndrome, that it was very challenging for us to see those people. In fact, they end up going onto the wait list as a routine referral, and there was no capacity really to see them, and so they just sat there. And so when I became head, people were being told that their wait time was 2 years, but of course their wait time was forever because urgent cases just kept coming in. And so obviously the patients were extremely unhappy, the family doctors were extremely unhappy, and the specialists were extremely unhappy, and I'm sure the government was extremely unhappy. So there was no happy people, and so just decided the only way to really deal with it was just to sit down with the family doctors and work out a solution that everyone felt was a reasonable approach. And so we just started to do a very collaborative meeting. We met once a month for 2 hours. And we had a special retreat where we invited the government and lawyers and everyone we could possibly find. We invited, or that was willing to come, and people were willing to come. It was quite interesting, like CMPA, the College of Physicians and Surgeons of Alberta, you name it, they came, and we just talked about wait times and what it meant, and wait lists, and legal liabilities, patient issues, all that stuff. And so to make everyone comfortable that if we made a strategy to deal with it, actually it was going to be in everyone's best interest. And as long as it was patient-centric and patient-focused, then everyone could potentially win. And so we started with dyspepsia first, GERD, so gastroesophageal reflux disease, and then we went through all of our common routine referrals, and with sitting down at the table with the primary care physicians, we worked out these pathways. We worked out, they were all on one page as a flow thing, but we had all of this supporting document where people could go and so they could get more information. And what it allowed and it was essentially so that we could say, we can't see these patients, but if you go through this pathway and they're still having trouble, then we can see them, and we'll see them. That's our agreement with you. But there are some things that if you do in primary care, that you can actually make most of these patients will be very happy because you'll be able to deal with their problem there. And so we started to launch these pathways we started with the one with gastroesophageal reflux disease or heartburn, and then we kind of went through them all up to chronic diarrhea, chronic abdominal pain. We have a whole ton of them now. And they've been unbelievably successful. Our over a year and a half period, our wait list for routine referrals went from about almost 3,000, say 2,800, down to zero. And so and of all the patients that ended up not coming to see a specialist, we 16% of those patients. So we did a survey of about 1,300 of them. About 16% of them end up coming back and getting a scope at some point in 2 years after they were put on the pathway. But most of them came back for something that was not related to their original referral, and they were scoped for something completely different. But also, there was no cancers found, so there was no serious pathology found in them. So we felt we had a very good, validated pathway patient, and we've done all these surveys afterwards. The family doctors love it. The specialists quite enjoy it because it's allowed them to really bond again with family doctors in a way that they'd kind of separated over the years. It was more of an animosity thing. In fact, GI for years have been ranked the worst, the least accessible subspecialty in medicine, and so we're not the worst anymore. So
congratulations on that.
That's right. Yeah. It's a high bar.
Yeah. But it sounds like it's also a case study for change management.
Exactly.
Where it took a sense of urgency to trigger the interest in coming together, and then you formed a guiding coalition of people to solve the problem. And I'm sure you went through that entire stepwise approach to managing change, and celebrating some quick wins and so on and so forth.
Yeah, exactly, and that's exactly it. And so the family physicians in Calgary are quite well organized. They have primary care networks, they're called, and so we would go through their leadership, but also they have a very actively read newsletter and things like that. So we would let people know what successes had been achieved, what they as primary care physicians had achieved, and it was very well received because they felt like they were kind of in the loop, right? It wasn't the traditional model, which is part of the reason why specialists in primary care were having some issues in the past, where specialists would say, this is how I want it done if I'm going to see your patient. And of course, that doesn't work, right? There has to be a collaborative discussion. It has to be what works for both of us here. And so I think by feeding back how that collaboration was positively impacting their patients, and I think themselves, I think they felt because they could turn the screen with this pathway on it and show the patient, say, this is where you are. This is what we're going to do next. If that doesn't work, we're going to do this next. And if it doesn't work, then you're going to go see a gastroenterologist. I think patients really like that. They found like they were connected to the healthcare system. They weren't like in the past. It was like, okay, you have an appointment in 2 years.
Yeah.
Don't worry, that appointment's going to happen. Of course, it doesn't happen, right? And so someone's waiting there in this black hole for 2 years, and no one calls. Right? It's like a bad date, right?
You've been ghosted by the healthcare system.
That's right. Yeah.
So I'm sure you're aware that there's many communities around the country that face the problem today that you were facing. How do you go about sharing? Obviously publishing is a great way to share this, but I'm sure you're having a lot of conversations with different leaders around the country on how they could also do something similar.
Yeah, many, and so obviously I'm very open with sharing whatever was successful, and because I believe this is a huge issue, and obviously you mentioned it is a huge issue all across the country. Also, we've made our pathways public, so they can be freely downloaded without restriction from specialistlink.ca. And so I've had people download them from France and Germany, all over the world.
Fantastic.
And they can't believe that they can just click on it and they have it. And I said, you know what? If you want to modify it, you go and modify it. There's no patent, nothing. There's no IP, and so you just modify it to your own area. And obviously things might not work quite the same way in the different area that works here, but it's totally modifiable. And I think the broad concepts and the education stuff that goes with it for patients is applicable broadly. It's all evidence-based, validated, and so I think it allows specialists, especially obviously gastroenterologists, but this has been adopted by all the medical specialties in Calgary, and now it's being spun out provincially as well. So I think that people see the real merits in having a guide like that because there's so many referrals into specialist care as populations grow and people get older. that there's this constant feeling of that, like the zombies flowing over the top, that you just can't keep up, and you're going to get overwhelmed, and then there'll be no one left. You'll burn out, right? And I think a lot of physicians were burning out or feeling burnt out, and so this kind of, I think, gives an opportunity for physicians to not burn out, to empower them to feel that they can deal with the cases that most need their input. Like, I think if patients can be dealt with a pathway with their primary care physician, who's really who they know best, rather than going to a specialist who really might not add any value to that whole interaction, just waiting for 2 years to get told stuff that maybe the family doctor's already told them, or not offer any additional value. I think it's a better structure to have it all do as much as you can in primary care, and then if you really need help, get a specialist help, and then the specialist can actually help you, because they actually have the energy, time, all the stuff you need to do a great consult.
Yeah, and if you combine these theories with these principles with now the backlog that's come through COVID, will there be an opportunity to further triage the waiting list that has developed?
Yeah, well, so it's the fascinating thing about COVID in Calgary, and I'm going to see, it'll be very interesting to see how this plays out. Is that so? When COVID started, of course, we weren't seeing anyone in our clinics anymore, essentially, unless you were urgent, really urgent. Right. And so what we had to do is we had to adapt to telemedicine, and this is not the traditional referral thing. And so we started to phone people. And it was fascinating, because we would phone people even on our urgent list and say, hey, I'm calling you about the blah blah, and they go, oh, I haven't had a problem with that for 8 months, And so then you talk about COVID a bit, then that would be it, right? It was, and so they were still on the wait list, but they were actually not really having an active issue anymore. And so it's allowed us to really reflect on who's sitting on our wait list, and could we do other things? So we're starting to think about maybe other ways that we could do this. Maybe have nurses call who are trained in that area and say, hey, look, are you still having this problem? I mean, just something basic like that, right?
Yeah.
And if they aren't, then, well, that's fantastic. Well, maybe we'll just cancel your appointment, let someone else move in.
Yeah.
And the other thing is, because there's a certain efficiency that comes with telephone consults, we actually did it. We were able to make tremendous inroads into our wait list. In fact, our wait list went. Our overall wait list now, if you include everything, not just our routine zero, but our wait list now was about 3,000 before COVID. Now it's 1,000.
Wow.
So we were able to actually do an amazing job, partly because fewer referrals were coming through, but also because the efficiency of this telemedicine. And so, I think we're starting at a lower number. Then we thought, okay, well, COVID's going to end. We're going to open up because we have a central access and triage that processes all our referrals. I said, well, as soon as we open that door and people realize that's open, it's going to be flooded again. But interestingly, it didn't. It came up, and it's kind of gone back up to where it went before, maybe just a little bit below that. So, I think there's something about the pattern of practice has changed, and I think time will tell us what it is. But it could, that could be the silver lining out of this, is that we might be able to be a bit more efficient in how we handle patients that are flowed through in a way that still makes everyone happy.
Yeah.
And so I'm quite excited about that opportunity.
Telemedicine has been around for quite a while, right? But it took something like this maybe to really demonstrate the value, funny enough.
Yeah. Well, it's funny because I have a friend who's a dean of medicine in the UK, and he said they've been pushing to try to do more online courses for the last 9 years. And he said that he said maybe they've had 2,000 meetings. They've had maybe one course go online. COVID hit, and within 2.5 weeks, all the courses were online. And he said, so it just shows you, when you guys want to do something and they're motivated to do it, man, oh man, the sky's the limit.
Yeah, and you're right. We won't go back in many cases because we found a more efficient way. To do this.
And it might be a hybrid. I think it'll be a hybrid model in the end. And I think that there's some people that especially in Canada, which is such a vast country, having someone drive 3 hours for an appointment, when they don't really have to drive, they can just do it over like a Zoom chat or whatever. I actually think that's way more patient centric, and patients love it. They just love it, right? And so I do think I mean, some people want to see their doctor and they want to, and I think it's important for some people to have that personal face-to-face contact. But a lot of people are totally happy to have it all done by telehealth. So I think a hybrid, I think, will suit. You can model it after whatever the patient wants, really.
Yeah, great. Now, one area which probably could benefit greatly from this type of approach is the non-alcoholic fatty liver disease that you've been working on for quite a time, and recently have done some press around. Could you speak a little about this condition and why this could or is already becoming a very serious health crisis here in Canada?
So, it's interesting because this is, also goes on with my history as a liver specialist, because, of course, fatty liver disease has been around for a long time. And so non-alcoholic fatty liver disease means, so alcohol can cause fatty liver disease, but people that don't drink at all have been known for a long time to get fatty liver disease too. It's usually associated with being overweight, especially fat around kind of the middle, and diabetes. Those are the main, and people with high cholesterol. Those are the sort of the things, and metabolic syndrome is if you throw high blood pressure in there, and so we knew it was an entity, but we always felt it was benign. Didn't do anything. It was just like fat anywhere else, just kind of sat there. It wasn't a worry. And I remember telling patients, don't worry, this is nothing, don't worry. Partly because what we know now, what we know is that we know about 25 to 30% of Canadian adults have fatty liver disease. And it's a growing epidemic amongst children as children obesity gets to be more of an issue. And so it is extremely common, like extremely common.
Okay.
Yeah, the problem and the issue is, though, only 2 to 3% of the Canadian population has what's called non-alcoholic steatohepatitis, or NASH is the fancy. So one's called NAFL, non-alcoholic fatty liver disease, which is kind of the whole spectrum of everything. And NASH is actually when the immune system for some reason decides that the fat should not be there in the liver, and the fat causes a little bit of inflammation. The immune system goes in to clean it up, and so it actually destroys liver cells as part of that. And if you destroy enough liver cells, then you start to heal. The liver tries to heal itself by scarring. You get enough scarring in the liver, then that's what cirrhosis is, just lots of scarring in the liver. And so there is a subgroup of people that have non-alcoholic fatty liver disease, or NAFL, that actually end up getting cirrhosis.
Wow.
But it's a relatively small number. And so you have this giant sort of numbers of prevalence of people with fatty liver disease in Canada. How could you possibly ever pick out the ones that are going to get into trouble? And so, as humans so often do, we just said, well, I think it's a benign disease, right? And that was it, right? But now we recognize that's not true in those small numbers, and so we need to figure out ways to try to pull those people out of the group of people that it's not a liver problem they have. They might have fat in the liver, but it's not a liver problem. It's a problem with their broad metabolism, and and there are other people, not a liver specialist, should be looking after them, and the fatty liver disease, and those people will get better. Diet, exercise, all the things that we all know about, and making sure that their cholesterol is controlled and their blood pressure is controlled, so they don't die of strokes and heart attack. But the people with the liver condition, there are different ideas on how to try to pull them out, and one of them is you can use blood tests, and those blood tests can actually tell you if people have, or suggest if people are more likely to have more scarring. But what we decided to do in Calgary is we partnered with the primary care physicians, and we partnered with the largest radiology provider in Calgary, who agreed to do all of the prerequisites to make sure that they were doing quality tests. And so we actually took what was recommended to do these kind of testing in Europe, and they followed that. And so we were comfortable that they could do reproducible, high quality testing. And what it is an ultrasound based technique, which is in the community. So an ultrasound, you go for an ultrasound, but there's actually, it puts a sound pulse wave through the liver, and it gives you a reading for liver stiffness. And in specialist clinics, they have something called a fiber scan, which is the same technology, but this is actually in the community. And then we made a pathway around that called the NAFLD pathway. And we then said to the family physicians, we're going to empower you to order this. If you have a patient with fatty liver disease or suspected fatty liver disease, then this is a test that you order. And if you order this test and if it's below a certain cutoff, and we pick the cutoff based on the literature, then they don't need to see us. And here's how you should manage them for their non-liver issue. If it's above that cutoff, then they probably should see a liver specialist.
Okay.
And so it's been very, very effective at kind of weeding out the people that don't need to see us, which is actually turns out to be over 90% don't need to come see a specialist. So our referrals for fatty liver disease used to be our number one referral, and it still is a very high referral rate, but it's dropped off hugely because what would happen is most of these people would come, we would do a fiber scan in our clinic, and we'd say, you know what, you don't really have any livers. You have fat in your liver, but you don't have disease. You don't have scarring. And so you have a low risk of progressing. So, let's work on your metabolic things, but that's really more in the family physician's arena, not in the liver specialist arena. So we think we more appropriately placed people where they're going to get the best care and avoided them, driving 3 hours to go see a specialist to say, look, your liver's fine, as opposed to having it done and then not driving 3 hours and having their family doctor work on the things that they need to work on to make them live longer that has nothing to do with their liver.
Yeah. Now Calgary set up around 6 centers. And so how has that helped you manage certain conditions, like the patients that do need to see a specialist for a disease like this?
So I think we're very, very fortunate in Calgary in that we have, despite the fact we're 1.4 million people, the GI division is for the whole city. So I'm actually head of all of GI, not just the university, and which is a little different because in different parts of Canada, it's often like each hospital would be its own sort of, I guess.
Yeah, I think it's pretty rare the setup in Calgary. I really do.
Yeah, very rare. And umbrella therapeutic endoscopy, endoscopic approaches to disease to try to prevent surgery, essentially.
Yeah.
And then we have a nutrition. We have something called Ascend, which is a nutrition center of excellence, which is really looking at how we can modulate the microbiome to treat disease, but also how we can treat things like IBD and cirrhosis more effectively through nutrition. And then, of course, we have the colon cancer screening center, which I think is unique, possibly in the world, actually.
Yeah.
I mean, they do sort of 16 to 20,000 colonoscopies a year, and it's completely dedicated to colon cancer screening. They have their own central access and triage. They're very they're fit driven. So the people who have a positive fit test are the ones that are scoped there mainly. So it's the people who are being scoped are very appropriate. So appropriateness is a huge part. And then they have one of the most rigorous quality programs I think you're going to find anywhere. And you have to hit a certain quality benchmark to be able to scope there. And so I think it provides a huge value. I think because of they do so many numbers and they have such a streamlined machine that I think the cost per procedure is quite acceptable, and which would tie into Bill 30 later. The cost of procedure is quite acceptable, but also it checks all the check marks for appropriateness and for quality. I don't think you're going to get any more value for your money because the people that are coming there are completely appropriate to be done. And the quality that you're going to get out of doing that procedure is as high as you're going to get anywhere in the world. And so I think that's a jewel, that the colon cancer screening center, and a very unique thing to Calgary.
Yeah. Now, you've done a tremendous amount of work building the system, this capability. You've added a lot of talented people also, over the last few years to be able to deliver this high standard of care, which is focused on patient outcomes. And recently, of course, the Alberta Ministry of Health, passed a new bill through the government, Bill 30, which now allows private corporations to be funded through taxpayer dollars. How do you think that's going to impact something like, what Calgary's been able to achieve and set up, or is it too early to tell, or what are your concerns?
I mean, it's a huge question. In fact, we just had a division-wide chat last week about it. But it's uh, you know, what originally drove it, of course, I believe, was more surgical wait times, and so originally I think it was, how can we deal with surgical wait lists and wait times, and so there was the idea, well, we'll build, maybe we can allow people to build surgical facilities, and then people could go through those facilities, but still be essentially the reimbursement would be the same as if they're going through a public AHS facility, but it would allow the volume to increase. So the wait list could be, and so, and I think a lot of people, certainly if you're waiting for hip for 2 years, I think I get it. No one wants it. When it's you, it's not routine. If it's someone else, it's routine, right? And so I get that completely. Obviously there are, the most important thing of any of these kind of things are appropriateness and quality, not just cost. And I think you want to put them all together. But so that's on the surgical side. The issue that's come up, of course, for gastroenterology is that. Of course, GI is procedure driven, and so with endoscopy, I don't think the government originally was thinking of endoscopy, but obviously, if you think that a lot of endoscopy, well, most places the endoscopy is done within hospitals, and so if you move that out of an acute care hospital, well, can you deliver that more cheaply? And so now that discussion has started to come up, and also not so much in Calgary, but if you look in other parts of the province, where FIT is the main driver of colonoscopy, the wait times in some parts of the province were really unacceptable, and so the government had put quite a bit of money in to try to fix that, but that was not the case in Calgary ever. Mm-hmm. Calgary always had amazing wait times for FIT, it's 6 to 8 weeks to get a colonoscopy. I mean, this is good. You're not going to find that as good anywhere else. Mm-hmm. And as I say, cost effective, appropriate, and highest quality. So I think Calgary. I don't even know how it's going to impact Calgary. Obviously, when it's a business proposition, I think people will have a model that may be cost effective. The problem is that we don't want to recreate what happened in Ontario. I think that has been a disaster. I think the problem in Ontario, of course, is that they end up doing a lot of scopes, and because the scopes are done with a anesthetist, often with propofol, they're very expensive. The appropriateness, because they're not driven by the same sort of things like FIT, or they haven't done a kind of a central access and then distribute. It's just free for all, totally free business, free enterprise. So when people are competing for business, of course, then you're gonna then appropriateness. The strict guidelines might not be followed, whether or not it's when you should come back for a repeat colonoscopy, should you have a colonoscopy at all, those kinds of things. Yeah. And then quality I think has been a big issue. People have found that that people are coming back with higher frequencies of interval cancers. They end up going for more scopes because they have not been done very effectively at the beginning. So I don't think recreating that in Alberta. I think we'll end up spending more money. People that don't need scopes will get scoped, and I think the quality will be less. So I think the government's aware of that. I know there's been some discussion about making sure appropriateness and quality are maintained. And so I believe as long as its cost, appropriateness, and quality are put into the equation, and they're all viewed as important for the best patient care, and patients are always put in the center of that. I'm very anxious to see how it will unfold. If it's not part of that, then I'm very worried that it won't unfold optimally. Obviously, in places that have been challenged with having patients that come through with FIT, I think that when you have something like a FIT test that's positive, we know that 3 to 5% of those patients are going to have a cancer or pre-malignant condition. They need to be scoped, and waiting a year with a FIT positive or whatever more, I think that makes me very nervous, and so I think the system has to be better than that. And I think, I think the model in Calgary is a model that could be used in the whole province. Actually, I think that these high throughput, dedicated colon cancer screening centers that have excellent endoscopists and the people that come there are appropriate for being there, and that the quality is that comes out is going to obviously be high because you're dealing with highly skilled endoscopists and appropriate patients. And then some way of following that quality. So whether it's with a system like an EndoPro, or some kind of system to document, so people can then go back and refer back to quality and be able to follow that going forward, I think is absolutely critical to making it cost effective. Otherwise, it'll explode into something where scopes are being done in a lot of places, maybe not appropriately, and the quality will be suspect.
Now, when you look at a fit positive patient going for a procedure, is there also just an increased risk of, the invasiveness of the therapy that may be required, and why it may be more appropriate to have that in, more of a medical center than a clinic?
What happens in Ontario often is if someone comes and they end up they're fit positive, that's so they're appropriate. They come and they get their scope, and then they go, oh, this person's got a big polyp. I'm not very comfortable taking that out. So I'm going to send you to the special center to get this done, or an acute care center. So that person just went through a colonoscopy. Sure, you found that they had a polyp, but now they have to do it all again. Yeah. And so every time you do a prep, and especially, there are risks with everything. Every procedure has a risk. And I think that's a disservice. First of all, you've just doubled the cost. And secondly, you put that poor patient through 2 bowel preps. And I think that for every time someone gets that done, maybe the endoscopist should do a bowel prep. that would stop that. That's a disincentive.
Yes. Yeah. And then also, you mentioned, how do you drive this quality? What were some of the things that you would ensure? Tracking, obviously, whether it be electronic or non-electronic, is critical. The measures of quality are totally critical. And so you're saying in Alberta that would have to be part of the equation if we're going to maintain any chance of quality. But that hasn't happened in many other parts of the country. There's no mandatory quality reporting at all. So that has continued to be a big challenge.
Yeah, and you know what? I think as healthcare budgets get tighter, I think that if people aren't looking at quality and appropriateness, then they're actually spending money on stuff that money should never have been spent for, or they're wasting money. Mm-hmm. And so I think that in the days of flush budgets and everything, I think that probably that was less concerned about that. But now healthcare spending is such a huge driver of every provincial budget, and so I think that you've got the benefit of having some sort of system of tracking. So for colonoscopy, you want to make sure you're getting the CECM. You want to do a withdrawal time that's going to allow you to see the polyps. And then you have to know that the people doing those colonoscopies are picking up polyps at a rate that tells you that they're excellent, and so those are the minimum standards that you really have to have, and you have to have a system that's designed to make sure people are doing good bowel prep, so you can have a good look around and all that kind of stuff. And so by focusing on quality, actually, the patient outcomes are going to be better. You've got if you're dealing with appropriate patients, if it's quality driven, you're only going to have the best endoscopists doing it. And frankly, if I'm going to get a colonoscopy, I want the best endoscopist that I can get, or at least someone I know that's excellent, not marginal. No one ever says, "Hey, look, I'm a marginal colonoscopist, but I'd like to do your colonoscopy." Most people say, "You know what? I might just look for somebody else."
Well, and I think then there's the whole aspect of cost, and so if you don't have a quality procedure, there's a chance that there's something missed. That if you're really talking just about cost to the healthcare system, a downstream cancer is a lot more costly to manage and treat than doing a good screening colonoscopy.
Yeah, not to mention the horrors of having a cancer in a patient, right? So all of the patient aspects of cancer, so the societal cost and the personal cost, and then the financial cost, right? And I mean, I think all of the systems, wherever they are coming more to that. Like if you go to the NHS, I mean, in England, they have very, very important and very strict quality guidelines, and that's across the whole country. And they're mandated. If you don't reach those if you can't do a quality colonoscopy, you're actually not allowed to do them as part of that program. And I just think that is just common sense. That obviously there are some areas in where it's very hard to get people that are as highly trained, but in the end, if you're not doing quality colonoscopies, then the cost to everyone, whether it's a personal cost, a societal cost, or a fiscal cost, is I think it just can't be sustained. And it's just a matter of when, not if. That it has to change.
Yeah. Now, do you think at all the move on Bill 30 was also financially motivated in that it was a way for the government to save money? You talked about the tremendous economic pressure healthcare is under, the province is under with the economy and so forth. Is that where we get into trouble, where we're looking to save money at maybe the expense of patient care and the outcomes that we really want?
So that's always the balance, right? And I think everyone sees the importance of saving money. I mean, the pot isn't just growing, exponentially anymore. And of course, in Alberta with the oil where it's at, it's devastated the economy. And I don't think anyone can look around and say this economy has not been very, very badly hit. And so I think people want to be part of the solution. And so, however, I think that, and I understand the government, because it's a conservative government, they've always believed in if you can get some sort of more private enterprise into it, then that should breed more savings. And I understand that, and I'm not, I think as long as it's done in a way that where appropriateness and quality are still part of that, and everyone's going to fiddle around with the balance in the end. And I guess if you have no money left in the coffer, then it's irrelevant, right? And if you have $10, then and that's what you're going to spend on the colonoscopy, then that's what you're going to spend, and you're not going to get great quality or whatever, but that's just the way it is. And I think in the end, when you're still working out these balances, because we're just trying to figure out how to do this, I think in a more broad sense, and I don't think anyone feels that it shouldn't be done, because why wouldn't you want the most appropriate people getting a procedure of any sort, whether it's surgery or colonoscopy? And then when you're done, you want to come and go, boy, that scar looks great, I feel great, or boy, that colonoscopy wasn't so bad, And I mean, people come out of the colon cancer screening center and they go, this place is amazing, and so patient satisfaction is extremely high. They know they've had an unbelievably good procedure done by someone who's extremely skilled and qualified. If their polyp was taken out, then they're cured of their potential cancer, and that is what healthcare should be. And so I think as long as people are working in that kind of sphere, I think that whether it's done privately or if it's done publicly or a hybrid thereof, I'm open to hearing what the kind of solutions are. The problem, of course, is that sometimes there's vacuums of information breed fear, and so obviously from the side of the specialists, if you're not hearing information, or you feel like there's a void of information, then sometimes obviously fear breeds speculation. Speculation often is not correct, and bad, it breeds bad decisions. And so I'm hoping that there will be an open dialogue, and I know there's a lot of strain between physicians and the government, but certainly the AMA and the government, But I don't think that means that we shouldn't be sitting down and having some dialogue. And I think cooler heads have to prevail as long as we keep the patient center and as the most important person, and understand that cost is extremely important, but that appropriateness and quality have to be tied in there to make sure that they're getting the most out of their money.
Yeah.
I think that there's some good things could be done.
Well, perhaps the good thing is you have an established model for that, and how you communicated and was engaged the broader community, including the government, around the clinical pathway development, and hopefully that can maybe serve as a model to come out with a good solution with this as well.
I'm hoping.
Yeah, you're hoping. Well, Mark, you have so much to be proud of in what you and your colleagues and the community has developed there in Calgary. I think it's incredibly impressive, and it's always great to hear someone talk about the patient care, the outcomes, the patient and provider experience, and cost, all in the same decision-making model. So I really appreciate your time today. It's been a fantastic talk, and hope to talk to you again soon.
Yeah, it's been a real pleasure. Thanks so much.
All right. Thank you.
Okay,
Bye now.
Take care. Bye-bye.